Hello, everyone. Welcome to the Comprehensive Sexuality Education, a Global Learning and Sharing Symposium on Health, Wellbeing, Values, and Equity. This panel focuses on case studies on unwanted pregnancies and abortion, and we have two excellent speakers, Atul Chandage from the Humsafar Trust India and Chansa Innocent from the Contact Trust Youth Association Zambia. So our first speaker today is Atul Chandage, who will be sharing with us about Medical Termination of Pregnancy Amendment Act 2021, Inclusivity Analysis of Indian Abortion Law for LGBTIQ community. And here's a brief bio about Atul. Atul Chandage is currently working as a counselor in the NetReach project under the Humsafar Trust. Atul's work includes providing information and services related to HIV/STI testing, PrEP, and PEP, bridging the gap between professional mental health counselors and clients, creating awareness about chemsex, and helping people in need to get proper sexual health services. Atul has been involved in linking key populations who use drugs to de-addiction services. Atul is also working to provide crisis management responses to high-risk populations. Atul also has been volunteering as peer support for the pale HIV group called Sanjivani since 2017. And Atul has been volunteering with the Impulse group in the Mumbai chapter, Impulse Mumbai, which is a gay collective working towards safe sex practices and advocating for HIV, mental health, and substance abuse. Since Atul has joined the group, Atul has been a part of their board in various capacities, such as executive board member, director of operations, vice president, and currently director of events. The floor is yours, Atul.
Thank you so much, Shamla. I would like to start the presentation. So the topic of my presentation is Medical Termination of Pregnancy Amendment Act 2021. It is an inclusivity analysis of Indian abortion law for the LGBTQI plus community. So the reason for me to select this topic is that most often we forget that when we're making policies or when we're writing acts, we mostly tend to forget populations like lesbian, bisexual, and transgenders, especially trans men, or also gender non-conforming people who are non-binary, that they are capable of conception. And because of that, there is a need for safer abortion services for these populations. Not just that, unsafe abortion is a medical legal problem across the globe, and it not only affects the LGBTQI plus community, but also there are significant barriers to accessing safer abortion services, even by cisgender heterosexual women. And unfortunately, there is no data on pregnancy and abortion practices among the LGBTQI plus population in India. So the problem that we realized is that the Medical Termination of Pregnancy Act 2021 is an amendment of the Act initially drafted in 1971 to streamline safe abortion services in India. However, the healthcare system ignores the need of the safer sex abortion services for the LGBTQI communities, not only in India, but across the globe. And unfortunately, like no analysis has been conducted to understand the inclusive nature of this act in India. So my objective is that of the study is to analyze the Medical Termination Pregnancy Act 2021 from the perspective of LGBTQI inclusion in India. The methods that we used in the study involved the following two processes. One, we had a descriptive analysis by relevant expert, and second, we had a focus group discussion with community representatives. The two parts of the Act gazetted for the Ministry of Law and Justice and the Ministry of Health and Family Welfare were analyzed by the team of policy, public health, and legal experts from the community. The consultation that was conducted was to triangulate the findings of the analysis. The consultation was conducted over a Zoom call. The notes were analyzed through deductive thematic analysis, and the findings of the consultation were then validated by the respective community representatives. What we found out that this updated version is oblivious to the needs for the abortion services of the LGBTQI communities in India. We say so because the consultation that we had people from the bisexual community, we had people from the lesbian community, people from the transgender community, and that's when we realized that the analysis reported the negligent language of the legislation as it mentions pregnancy from a very heteronormative perspective only and excludes gender neutral terms and specific pronouns. So when we talk about this, we basically also see the subtlety of how the policy neglects or ignores these kind of minorities, because when you do not use these terms in the act, you basically telling that you do not have space here, and that is the problem. That because later on when we talk about policies, we have something on the paper, and that's what we can use to defend our rights. But if something is not there for the community, when we do not specify these things in the policies, that directly means or indirectly means that you will not be included. All the reporting documents also use cisgender heteronormative salutations. Again, this is like neglecting or the fact that there are people who do not fit in the binaries of gender and sexuality. And for that, like we know, nowadays we are been using these terms of he, she, they, them, whereas the Policy Act only uses the he and the she. But what about the trans people? What are the people who do not find themselves in these binaries? What about them? Also, that the act talks about the eligibility criteria, which includes sexual assault and rape as an eligibility criteria for allowing abortion under this act, which is not applicable to non-binary, trans, and queer individuals, as the rape laws are not inclusive of the community despite higher incidences of sexual harassment. So here again, we simultaneously we also went through a little bit of the rape laws, and then there also we realized that if in the rape laws itself, the government does not recognize the fact that not only women but people with uterus, it could be a trans man, it could be people of who do not identify as any gender or who are gender non-conforming. Even they go through all of these things. We have people from the LGBT, the lesbian community, the bisexual community, the gay community, who do go through all of these, sexual harassment at a very higher percentage in the community. But these individuals or these communities are not being acknowledged in the act, in the rape laws, and therefore the same has been reflected when it comes to abortion, because the government does not consider trans men to be raped. They haven't given the provision for them for abortion in their acts, and that is one of the disturbing factors for us. We further, there will be a medical board deciding the factor of abortion, which will be, using an institutional approach with no community representative. Forget community representative, the board may not even have a psychologist to understand the mind state of the person. And this board could consist of anybody they deem fit to be, sitting on the other side. So this completely takes the individual right to decide for themselves. So this whole concept of my body, my decision goes totally down the drains when it comes to a board deciding. Why should a board decide? And even if there is a board, is there somebody from the community to take our side? Because obviously, given the fact that we come from a very patriarchal, male-dominant community, if the male dominated board decides that okay, this person cannot go for abortion, then the person cannot go for abortion, and that is risky, because um, because the community representative also pointed out that the unsaid requirement of a cisgender man as an attending and a decision making partner to avail these services and single stated pregnancy as the major challenge to delivering LGBTQI plus inclusive abortion services. So here also I would like to relate these 2 points, because at the end of this, if this is what is happening, if a board decides or if there is no male partner accompanying during abortion, the person might go to anybody just to get the abortion done. those crooks who are willing to take your money by putting your health at risk, and the individuals who are willing to give money and at the cost of their health, they are going to these are the decision points which I firmly believe will be driving that decision. So to conclude, what I would like to say is that there is a need for an intensive community consultation to explore the specific needs of the LGBTQI communities for abortion services and advocate for further amendments in the Act to ensure LGBTQI inclusive services, abortion services. To end up my slide, I would also like to add a note that when we look around us, there are super developed countries where the abortion rights are being snatched. And these abortion rights are of cisgender heterosexual women. So when people, I mean, when cisgender heterosexual women can go through such situation, it fears us that what would happen if tomorrow an LGBTQI plus person goes for abortion. So that is why now I feel is the right time that we obviously stand in solidarity and ask the rights of the cisgender heterosexual women for abortion, but at the same time also push the LGBTQI plus inclusive abortion services in the coming policies. Thank you.
Thank you, Atul, for the insightful sharing. The findings clearly establish the need for safe abortion services for LGBTIQ communities in India. We will have a discussion session once our second presenter has also presented. We now move to our second presenter, Chansa Innocent, who will be talking about unwanted pregnancies and unsafe abortion among in-school adolescents, a case study of Livingstone. And here is Chansa's bio. So Chansa Innocent holds a Bachelor of Arts degree in Demography from the University of Zambia and is currently pursuing a Master of Public Health degree in Health Policy and Management at the University of Zambia School of Public Health. He has a proven track record in adolescent and youth-focused programming. He is a Global Health Corps Fellow working at strengthening rural health systems with a Scottish charity called On Call Africa. He's also principal investigator for 2 research studies implemented by Contact Trust Youth Association funded by Grand Challenges Canada, exploring the role of teachers in solving issues of unwanted pregnancies and unsafe abortion among in-school adolescents in rural and peri-urban Livingstone, assessing the role of youth in addressing issues of unmet need for contraceptive care and education in Fansa district. He serves as a youth trustee on the board of Restless Development Zambia. Over to you, Chansa.
Thank you. Okay, great. So I'll dive into it. Okay, so I'm basically looking at teachers acting as frontline actors to resolve issues of unintended pregnancies and unsafe abortions among in-school adolescents. And this is basically based on the fact that teachers spend the bulk amount of time in school with adolescents, and therefore they are better placed to resolve issues of any unintended pregnancies or unsafe abortions as compared to parents who spend only a less amount of time with their kids at school. And this study was basically based on the comprehensive sexuality education curriculum, which the Ministry of Education here in Zambia is rolling out in schools. So through this study, we sought out to assess the operational feasibility and acceptability of using teachers as support structures to solve issues of unintended pregnancies and unsafe abortion among in-school adolescents. This was an exploratory qualitative study that was conducted in Livingstone District of Southern Province. We conducted about 20 focus group discussions with in-school adolescent girls. Then we also conducted 31 key informant interviews with guidance and counseling teachers. We also had conversations with pharmacists and a cadre of healthcare workers who is termed as adolescent focal point persons in the Ministry of Healthcare facilities here in Zambia. And we use thematic analysis with the aid of Vivo to analyze our findings. And our study also integrated gender transformative approaches. As just a way to sort of meaningfully engage young people and just dive into their lives, we used an approach called meaningful youth engagement, where we believe that young people understand their own realities better. So most of the research assistants that we used on this study were basically adolescents and young. And as part of our study, since we were trying to assess the operational feasibility of our study, among the frameworks that we used was the theoretical framework of acceptability, which we used to sort of assess the pre-feasibility of using teachers as support structures in the issue of unintended pregnancies and unsafe abortion among adolescents. Yeah, and analysis of this particular aspect of our study was guided by the theoretical framework of acceptability, which we adopted from SECON. Also, another framework that we added to the theoretical framework of acceptability is a socio-ecological model, which sort of helped us analyze how an adolescent's environment looks like in the community, at school, and just within themselves as people, as adolescents. And this is a snapshot of the findings that we got from our study. So several issues came out as regards what could work and what could not work out as regards teachers helping to support these issues. Actually, what we found out first is that the needs for young people are very diverse and they vary across schools characterized as rural and urban. And also we note that values, stereotypes, and perceptions have a bearing on not only the learners, but also the duty bearers who are teachers, who struggle between the delivery of CSE with adequate detail on one hand, and on the other hand, they tend to withdraw from delivering CSE to the adolescents. And third, we realize that integrating CSE in school curriculums in the Zambian context is sort of narrow, and it does not connect to the broader social and cultural dynamics within the communities and the schools in which CSE is supposed to be serving. So, and also from our findings, emerging lots of themes emerged, among which include things like enablers of unintended pregnancies, enablers of unsafe abortion, things like support systems, information sources, prevention and consequences of unwanted pregnancies, and things like that. I'll just highlight a few from these. For example, enablers of unsafe abortion. So from the conversations we had with young people, among the enablers of unsafe abortion include community people. So these community people could include the parents themselves, could be the grandmothers or grandparents to the adolescents, who maybe, for example, an adolescent falls pregnant would, instead of resorting to look for a safe method to end the pregnancy, but then they would just resort to the traditional ways that they know, which usually leads to unsafe abortion. Another issue that was brought out would be that, because for example, in the Zambian context, our abortion law is quite liberal, but then it is not readily known by people, and people do not know, especially adolescents, do not know that they can access this service safely. So as a result, people just tend to resort to unsafe abortion, and it is even worse for in-school adolescents, for fear that they would, the fear that society would ridicule them, that due to premarital pregnancy, for fear that their parents will not accept them, and maybe the person who got them pregnant will not accept. So those are some of the enablers of unsafe abortion. Then also among the issues that emerged were issues around support systems. So it's like there is in as much as schools implementing this CSE curriculum, there needs to be a linkage between the school system and the health system. But then there seems to be a disjoint between the school system and the health system, because the school system says adolescents are pupils and they cannot receive this service. Then when you go to the health system says these adolescents are our clients and they can receive the service. So it seems these two systems are working in silos, and hence the need to bring these two together. Yeah, and there's need for the CSE curriculum to just be tailored towards more sort of empowerment of young people or adolescents to understand and be able to resolve their own sexuality issues on their own. Yeah. Also, I want to just highlight a bit on what we found around the capacity of the intermediaries, which are the teachers in this case. We found that teachers were lacking in their capacity to effectively deliver CSE materials like in a youth-friendly manner. And none of the teachers in the 10 schools that we went to were trained in peer education. And on the other hand, we found that healthcare providers we talked to in the health facilities we went to had training. So this basically just shows that there's a disjoint between the two systems, which is the educational system and the Ministry of Health system. And adolescents pointed out that teachers only touch the surface and do not go in depth to teach CSE materials, leaving the pupils to find out on their own. And hence, from the findings of our study, suggests that Ministry of Education should invest more resources in building the capacity of their teachers in youth and adolescent-friendly methodologies, so that they could integrate this in the CSE curriculum in each and every school nationwide. So just to conclude, among the barriers to accessing adequate CSE knowledge on and SRHR include things which include community attitudes that create stigma around young men and women's ability to access services in clinics or ask questions or debate around CSE issues. Also, teachers' capacity that fails to adequately deliver CSE materials. We have school systems that have placed less emphasis on practical skills and tools related to CSE and the way it is just being delivered. Also, like I mentioned, the lack of linkages between the schools and healthcare facilities, and also the healthcare. In as much as healthcare providers are trained, their attitudes are very bad. So these are among the issues that are leading to young people or adolescents in schools to be having unwanted pregnancies and in the end resort to unsafe abortions. But then teachers are quite a resource in helping resolve this issue if they effectively deliver the CSE curriculum and the bulk amount of time that they spend with adolescents in school. So from the findings, I would recommend that there is need to have a systems approach when it comes to resolving this issue of unsafe abortions and unintended pregnancies among adolescents. So interventions around CSE should take on more of a systems approach, which means bringing everyone on board. That is the Ministry of Health, the community, parents, name them. Only through this sort of systems integrated approach can we be able to sort of alleviate this issue of unintended pregnancies and unsafe abortions among in-school adolescents. So from our study, we sort of came up with this that we're calling a triangle of hope sort of approach to ending unsafe abortions among in-school adolescents. So on the top there, we have organizations, for example, we have NGOs, charities that are working around SRHR, which includes CSE itself. And this side, we have the community, and we have healthcare providers and the teachers who have the mandate to deliver CSE. And on the middle, we have the adolescent girls themselves. So adolescent girls would benefit more if these three actors, who are the community, the NGOs, and the ministries through healthcare providers and teachers, sort of come together through a system-wide or a systems approach and only then. But right now, it's like, well, they're all working in silos. The parents in the community will say this, the NGOs will come in and say this, the healthcare providers will also come in and say this, and something like that. Yeah. Then last but not least, due to the societal norms surrounding adolescent sexual reproductive health access, especially in our context in Zambia, there is need to sort of clarify the values of the teachers, healthcare workers, and the community at large for the success of proposed interventions around CSE in schools. I'd suggest the IPAS VCAT model to sort of help clarify providers' attitudes. And the VCAT model is also good for advocacy. Yeah. And also just Ministry of Health and Ministry of Education should work in liaison to ensure that this is a success. And a recommendation I'd make to both Ministry of Health and Ministry of Education is that, for example, Ministry of Education has schools in Zambia which do not allow CSE to be taught to learners. So I think there's need to sort of bring both the health providers and the teachers in one space and advocate for a common goal. There should be some space where teachers in other schools that do not allow, especially for example, mission schools do not allow CSE to be taught, and these are places where we're even having high incidences of unwanted pregnancies. So if these other schools could also be brought on board, I feel it could be a good thing. I think Ministry of Education should strike deliberate effort in that manner. Then also, just last but not least, Ministry of Health and Education should integrate the CSE curriculum into the wider community attitudes, and that will help it achieve more results as compared to what is happening right now. Thank you.
Thank you, Chansa, for the great presentation on the status of unwanted pregnancies and unsafe abortion among in-school adolescents. We can now move to the discussion session. The first question is Atul and Chansa. Could you tell us a bit on the way forward, the future plans, especially in terms of advocacy actions based on the findings of both your research? Maybe we can have Atul go first and then Chansa.
Sure. So what was the first question? A way forward, right? Yeah. So in my opinion, the way forward should be that we need to have more consultations with stakeholders and include a gender-specific sensitive perspective in the MTP Act. So when we say that, when we go for consultation or when we call for consultation, we want people from these areas, so that the policy that is made or the act that comes up is very inclusive, and it should have community representation. Because if a policy or an act is coming into place and there is no community consultation, it will actually not have the essence, or it will not have that impact in the policy, because the community can speak for itself. The non-community people who are making the policies, they may not truly understand the issues and the importance of these inclusivity of abortion rights for the LGBTQI population. Yeah.
Thank you, Atul. Chansa, over to you.
Okay. The way forward, I feel they, just like Atul has brought out, so there is need to have deliberate conversations with especially community people, because if the CSE curriculum is to be very welcome in our society, then we expect community people who are like the gatekeepers, among which include parents, to understand it first. But I think that stage was sort of skipped there is a tendency to just use a top-down approach to key policy things like CSE, and the community does not accept that easily. So I think there should be deliberate efforts to use sort of a bottoms-up approach, where we first co-design CSE interventions with the communities that we want to save. And if we co-design these interventions with these people, then we will not have any fight back from the communities, because they were part and parcel from the inception. But if they are not part and parcel from the inception, definitely there's going to be fight back from the communities who have parents always saying, no, my children cannot be taught this because this is, you're telling them to be promiscuous and the like. So I think we need to sort of, firstly, we need to look at the communities not as beneficiaries in this development arena, but I think we should look at them as partners, and that way we'll go further.
Thank you for the strong points, Chansa. And I have another question. So maybe this one Atul can take, because I saw Chansa has already put forward some recommendations in his presentation earlier. So Atul, based on the plans that you shared, the future plans, what could be your 2 recommendations to advance the current situation on the issue that you're working on, with a particular focus on the role of CSC in these areas?
So when we talk about, 2 suggestions from my end would be that we need to have, data. There is no data for, when it comes to abortion and pregnancy of the LGBTQI plus community. So we need to start collecting those data so that it reflects on, to reach the evidence-based decision and amendments in the act. And also that the other thing that I would like to recommend or suggest is that we need to have gender neutral, gender inclusive and gender neutral terms or gender neutral terms in the policies, so that people do not feel left out. And now that we know that people are more and more aware of themselves and who have a voice, but because these policies lack these terms, they're being forced to be suppressed. So we need those things, and also along with that, we need to sensitize the healthcare workers. We need to sensitize people who are making these policies that cisgender heterosexual women are not the only one who can have can conceive. So we need to do. I mean, these are my 2 recommendations.
Those are some great recommendations, Atul. So yeah, we've come to the end of our session. Thank you very much, Atul. Thank you very much, Chansa, for the very, very informative sharing. And thank you everyone for your time.
Thank you. Thank you, Shamla, for being such a cooperative, moderator of this entire session. Thank you so much.
Thank you.
Thank you.
See you. Bye.
Bye.